Okay. I'm so glad to be here with you today. Thank you for the invitation, Dr. Nouran. And I'm so proud of being part of this scientific session concerned with the breast imaging. At the beginning, Bismillah ar-Rahman ar-Rahim, wa salatu wa salam ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. I'd like to have a very short moment of uttering a small prayer for the victims in Palestine and standing in solidarity with our victims there. ربنا يلطف بيهم. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. My session is about a new modality that is emerging in breast imaging. It's the positron emission mammography. My goal in this session is to cover some of these subjects, history and introduction, the biochemical basis or the biomedical basis of the examination, how to perform it as a technique, what are the indications and contraindications. Then we will elaborate on the interpretation of the PEM study, and we will discuss some interesting cases, cover some of the limitations, and have a take-home message. The history, in short, PEM studies started very early in the 1978 as a scintimammography study by Haisadi and his team, experimenting with the thallium-201 that was found to be an effective breast tumor-avid agent. Then a couple of studies were done later on in the 1990s by two teams on small scale, and found that the technetium-99M system EB had a higher sensitivity of finding the lesions. And another larger scale studied the technetium and found that the specificity of scintimammography was 85%. However, that was with the locally advanced and large breast masses, but on the study done by Tufani et al., they found that it was very low sensitivity in lesions less than 10 millimeters, and hence they looked at the limitation, and it was due to the application of a whole body gamma camera instead of a specific machine. And from here, the sensitivity and specificity was found to increase with a dedicated small focus of view gamma camera with detectors nearer to the breast tissue, and that increased the sensitivity for larger and smaller tumors. And with optimization and collimation of the images, even additional increase in sensitivity was suspected. As we see in this phantom images, one was on the table of a gamma camera, the other was closer to the detectors. The PEM is a functional imaging modality that depends on injecting a radioactive material that is widely used in the PET scan, and we're all familiar with, which is the fluorodeoxyglucose, the 18F-FDG, it's known for short. Also using a small field of view positron emission scanner that resembles a mammogram unit. The detectors are placed instead of the compression plates, so the views we find, as we see in the photo, are consistent with or monologues to the CC view, MLO view, and the axillary tail view. And it acquires a volume of the breast and then tomographically displays it. If we come to the biomedical basis of the PEM scanning, we know that a malignant cell is very active metabolically, and it has high demands of energy. So it uptakes the glucose through the glucose transferase enzyme, then phosphorylates it with the hexokinase, so it will use it as the glucose 6-phosphate in the glycolysis needed for the energy of the cells. However, when we inject the 18-FDG, it will also undergo the same cycle up till the phosphorylation, where the product, the 18-FDG phosphorylates, are not used in glycolysis. It's trapped within the cells, which emits the 511 kiloelectrovolts emitted in the opposite direction and detected by the PEM scanner. Here is the technique where the patient is asked to be fasting for 4 to 6 hours. Then the glucose level is measured. It should be less than 140 milligrams per deciliter. Then about 10.9 millicuries of FDG is injected intravenously. In some cases, you might need a quick scan of the site of injection, so you can make sure that there are no infiltration or muscle uptake, because this will interfere with the findings. Patient rests quietly for 1 hour, then she is subjected to the imaging, either on a vertical machine that's similar to a mammography machine, or another machine where the patient lies supine in the detector. Then we immobilize the breast between the gamma detectors, make sure she's not moving and she's sitting comfortably, because the examination will take a little bit of a time, as each position can take up to 5 minutes. So it's a total of 10 to 13 minutes for each breast. Then the images are displayed in a collection of 12 slices of MLA and CC views. The slice thickness is equal to the breast thickness divided by 12. When we come to the indications of PEM study, there are a large array of indications, and the main indication is when MRI and contrast-enhanced mammography are contraindicated, and that's when the patients are sensitive to the or allergic to the contrast material, or has renal impairment, or in the case of MRI, the patient is too obese for the machine, she has a pacemaker, or she's claustrophobic. The radio tracers is entrapped within the cells. This helps that we can clarify the biopsy result as positive and adequate. It's easily interpreted. We decrease the false positive results, and it has less effect of the background parenchymal uptake. We can use it to map the extent of invasive and non-invasive disease. The tomographic images helps surgeons make sure they will remove the whole mass without leaving any positive margins. It is helpful in follow-up of breast cancer therapy and to predict the response of new adjuvant chemotherapy, and also in identifying small cancers that may alter the diagnosis of the conventional images from multifocality and multicentricity. It's used as an adjunct tool. Yeah, it's not a stand-alone modality up till this moment. We find it helpful in equivocal findings, in enhancing lesions to further characterize it upon the metabolic activity. In cases where MRI and contrast-enhanced mammography are contraindicated, as we previously said, the multiplicity and disease extension for proper planning in the preoperative stage and in response to assess response to neoadjuvant chemotherapy. Here's a case of a 29 years old female with a palpable left breast lump that seems very suspicious on mammography. And she's allergic to the contrast medium, so the biopsy resolved an invasive ductal carcinoma grade 3, and for further assessment of the extensions, a PEM study was done, and it shows an intense radiotracer uptake. And this is the study after neoadjuvant chemotherapy, showing a good response with regression of the size and the PUV and LTB. We will elaborate on the cutoff values later in the interpretation session. How to interpret a PEM study? A PEM lexicon is a developing lexicon that's probably going to go along the BI-RADS lines of the MRI, although it's not integrated yet, but this is the expected path that we will use for the PEM lexicon as a reporting system. The classification of the lesion is the first item that we should consider. Solitary focus, which will probably be removed as regards to the latest lexicon, but up till my presentation, I didn't know this. This is a small lesion that's less than 4 millimeters that shows uptake on the PEM study. Maybe we find multiple foci, we should state that. Mass uptake and describe as rounded, oval, or regular. The non-mass uptake is a diffuse uptake with no 3 dimensions that can be focal, regional, linear, ductal, or segmental. We should state the lesion size and indicate the location of the lesion according to the side quadrant and the clock face. Associated features or findings that we might see, as in this case, are the nipple uptake that should be stated and the skin uptake, the qualitative and quantitative assessment that will be that I will elaborate on in the next slides, because these are the main difference or the main items that we should consider while reading a PEM scan. We should also comment on the homogeneity of the parenchymal background, being homogeneous, mild, moderate, or patchy and heterogeneous. Then, according to the 6-scale BI-RADS, we should give a final diagnosis. The qualitative FDG uptake within a finding might be positive or negative. Of course, if it's positive, it's probably, it needs further reading, but if it's negative, it will be probably benign. The quality of uptake, whether it's mild, moderate, or marked, the lesion form and size should be commented on, the extensions and multiplicity of the lesions, associated features as we covered in the previous slide. Then we can proceed to the quantitative assessment. There are 2 main parameters that we consider while reading the PEM scan. That the first one is the PEM uptake value, or for short PUV, and the malignant cutoff value, as stated by multiple studies. One is also included in Bahia, or was done in Bahia Hospital, is more than 1.95. While the other parameter is the lesion to background ratio, which is the cutoff value of which for the malignant lesions is more than 3.1. So we have 2 important values that we should remember, because this will be discussed later with the cases. We have the PUV maximum value more than 1.95, and the lesion to background more than 3.1. So if we consider the qualitative FDG uptake, if it's positive or negative, we said negative is probably benign, positive is probably needs further reading. In the quality, the mildly active or the mild uptake is probably benign. The moderate uptake might be malignant or benign. but the malignant moderate uptake is usually seen within the low activity of the lobular and DCIS carcinomas. The marked activity is probably malignant. However, some active benign lesions like the cellular fibroadenomas and the inflammatory breast may give a false positive marked uptake. This is a case to help us interpret the PEM study. This is a screening case that came in 2018 and 2020, found to have a developing focal asymmetry again. The old lexicon is just catching up with us. So a PEM study was done, and we find that this is a positive uptake, and it's a non-mass mild uptake. So we have to go to the quantitative assessment. The PUV max was 1.2, and the lesion to background was 2.4, which are very low. These are below the cutoff values that we've said before. And by biopsy post-surgically, it was multiple intraductal papillomas with sclerosing adenosis. The uptake of the tracer is correlated with a few factors, that the more the tracer uptake, the more the tumor grade is. It's high in triple negative, that is an active and aggressive tumor. It is decreased in lobular and DCIS. It's higher with a high risk of nodal metastasis, and sometimes it gives a good response to chemotherapy when it has a higher uptake. This is my first case to present to you. This case came in 2019 and 2020 with, she's a 48 years old lady with left breast developing asymmetry in the lower quadrant. This is the PEM scan of the left breast, where we can see the multiple masses and foci of enhancing lesions or tracer uptake in both the outer and inner quadrants. The PUV was 3.6 and LTB was 8.6. And this was a multicentric malignant lesion that proved on mastectomy to be invasive ductal carcinoma. The second case is a 48 years old female complaining of right breast swelling and induration that shows on mammography. On the isotope scan, the PEM scan shows a small mass with avid uptake. That has a PUV max of 1.96 and 4 LTB, and this was an infiltrating pleomorphic lobular carcinoma, and hence the lower readings, or it was almost a high normal reading. In this case, the 64 years old lady came with her left breast mass. And on the mammogram, we can find some also obscured lesions on the upper outer quadrant. The left mass was typically malignant on ultrasound, while the right breast mass was equivocal. The PEM study shows the right breast to have no uptake at all, negative study, confirming a benign nature, while on the left there was the index mass, intraductal extensions, and another focus that changed the case from unifocality to multicentric disease, and on mastectomy it was an invasive ductal carcinoma. This is the fourth case. It's a 60 years old female, also for screening. On the right, we find this tissue distortion with an underlying breast, irregular breast mass with ultrasound. Also on the left breast, we find a suspicious lesion. On the PEM scanning, the left side was negative for uptake, and on the right we have an AVID single mass that had a PUV max of 1.99 and the left 4.1, the LTB, wide local excision shows a new focal IDC. The biopsy from left breast shows fibrocystic changes. This is my last case. It's a screening mammogram of a 55-year-old female with a single view subtle asymmetry that was with an underlying irregular mass on ultrasound. Another lesion was seen to be a small parenchymal distortion in the left upper outer quadrant. This is the contrast mammography of the same case, showing faint focal non-mass enhancement, while on the left it was a small focus of enhancement that was reported to be probably benign. On the PEM, the mass is well discriminated, and it shows avid uptake, while the small focus on the left shows a very low uptake. But on biopsy, the right side was invasive ductal carcinoma. The left side was lobular carcinoma. This is the first limitation that we're going to explain here. The lobular carcinoma has low metabolic activity and vascularity, giving false negative results. In the PEM, we cannot really detect microcalcification. The whole body will be exposed to radiation. It's contraindicated in pregnant breastfeeding. Benign lesions such as rapidly growing fibroadenomas can have uptake. Acute and chronic inflammatory process like fat necrosis might also have a focal FDG uptake. Its non-inclusion, the non-inclusion of malignancy, as with mammography, can give negative results. Lesions in close proximity to the chest wall or in obese, breast, increased breast density may result in significantly higher FDG uptake. The take-home message is that PEM is a potentially helpful tool when used in the indicated sections, and it's a good adjunct modality. I advise you never to stop learning new modalities in the field of specialty. Try to know the following: how is it done, what are the indications, benefits and limitations, how much does it cost, and how cost effective it is, how can it benefit my patient, how to convey my findings to the clinician. Thank you very much.
Thank you, Dr. Amira, for your nice presentation and your courage.